I think we have a pretty good sense of the statistics by now, and we've heard a few presentations on this problem already over the past 3 days. But more than 64,000 people have died of a drug overdose in 2016. Approximately 50,000 of those deaths involved fentanyl, heroin, or other prescription opioids. Drug overdoses have become the leading cause of death for people under 50, driven primarily by the rise in the past few years of the synthetic opioid fentanyl. People suffering from substance use disorders interact daily with our criminal justice system. This is often the place where that problem becomes most acute. In this conversation, we're going to explore some of the strategies that justice system stakeholders have used to help battle this epidemic and help people get help for themselves. So I'm joined by three fantastic panelists whose bios are all worth a read. Darcel Clark, to my left, is the District Attorney of the Bronx, New York, a position she's held since 2016. She's the first woman in the position and the first African-American woman to be a District Attorney in the state of New York. Yes, so that's... she's also previously served as a judge in both the Bronx and in Manhattan. To her left is Brendan Cox. Brendan is the Director of Policing Strategies at the Lead National Support Bureau, which he'll talk a little bit more about. He previously served as the Chief of Police in Albany, New York, a department that he worked in for 23 years. And finally, to his left is Chris Rattan. He is the Executive Director of Alethea House, one of Alabama's oldest and largest substance use disorder treatment programs. And Chris has helped run that program and that organization for 40 years, which now that I've met you in person seems hard to believe. You must have been 19 when you took it over. But in that position, I think, and in that span of time, he's seen a tremendous amount of change in both the way drug abuse has presented itself and then also how treatment has presented itself. So, we've spoken quite a bit about this already, and one of the common principles or tropes in the discussion around opioids is the idea of the, college-bound high school football player, a varsity athlete who injures their shoulder and seeks prescription medication and ends up a few years later on heroin. Now, D.A. Clark, I want to turn to you first because you work in a very different community. Can you tell us a little bit about how this problem manifests itself in your community and maybe talk us through some of the programs that you're working on to try to battle it?
All right. Thank you, John, and thank you for the Center of Court Innovation for having this seminar. It's great to be here. Of course, in the Bronx, we partner with Center of Court Innovation and Bronx Community Solutions all the time, and I know your team is here. So thank you for all the work we do, and we'll talk about that a little later. In the Bronx, I grew up in the Bronx, New York, my whole life, and this opioid epidemic is nothing new to the Bronx because we've been here before. In the 60s and 70s, heroin was a big problem in New York City and in the Bronx. And several people came back from Vietnam and different communities in the Bronx. People came back addicted to heroin. And there were very few resources at that time as to how to deal with the epidemic. Medically assisted treatment began in that era. But now fast forward 40 years later, and I still have those same communities still dealing with the same problem of heroin addiction. Just right steps outside the courthouse, there's an area where there are two methadone clinics catty-corner to each other, and there are 60, 70 people a day standing out there still addicted to drugs. They have walkers, they have oxygen tanks, they're in wheelchairs. These are people who have dealt with this problem most of their lives, and here we are again dealing with a new opioid problem. And it's because, and the attention now is coming out because it's hitting different communities, like you said, than ever before. So I have a two-prong. I have those who have been historically addicted to drugs, and now those new drug users because of the painkillers.
And you have, though, developed two programs to help try to address this within your own community. Can you talk a little bit about OR maybe first, and then also the HOPE program?
All right, again, I want to thank Bronx Community Solutions for helping us with this. Maria Almonte Weston and Amy Warner both work with us every day in dealing with this. And also my Alternatives to Incarceration Chief, Aisha Green, is here as well. So they will correct me if I get anything wrong, okay? But OR is simply a program where it's the Overdose Avoidance and Recovery Program. And what that is for those high frequent users that have cycled in and out of the criminal justice system because of their addiction. These are individuals who, on average, has 7.5 or 8 arrests within their career as they keep cycling through the criminal justice. I shouldn't say arrests, I should say convictions, because they come through all the time. And what we wanted to do is, before a lot of drug treatment courts that we have now requires that an individual plead guilty first and then get the treatment. And then if they're successful in the treatment, their case is dismissed, or if it's a felony, it's reduced to a misdemeanor. With OR, this is for the low-level, straight possession of drugs. And as they come in, rather than drawing up the case and putting them through the criminal justice system, we stop the criminal justice process and give them treatment immediately. And that's treatment without them having to plead guilty. And this is a new phenomenon for so many, at least in New York State, because the way that we've been doing it is that they have to plead guilty first. We got a lot of buy-in, especially from the defense bar, because that is something that they've always wanted. Because in pleading guilty, even though the case is held in abeyance, there's immigration consequences, there's housing consequences, there's financial aid, all types of things that would impact the individual. So we're giving them treatment right away, connect them to it, and no treatment is the same. It's based on the individual. So we connect them to that, and once they meaningfully engage, and that engagement is different for every single individual, because again, it's not a cookie cutter, one size fit all. Once they meaningfully engage, then we dismiss the charges. Now, if they attempt, and we don't punish people for attempting to go into recovery or be clean. So this is not a carrot and a stick. This is all carrot. We want to save your life. That's the most important thing, and that's why we're doing this, because these are individuals who not only high frequent users, but on the path to overdose. And we looked at different statistics in order to determine who is eligible. So we're saving their life. That's the goal of it, not to put them through the system, but to save their life. So if they engage and then they're no longer interested, or they're eligible and they decide not to do it, we don't punish them. They go back into the regular criminal justice cycle, and still we try best not to send people to jail. It's just, again, to keep giving them the opportunity to get treatment.
At core, OR is a harm reduction program. We want to, as D.A. Clark's saying, we want to save your life. It's all carrot, no stick. I had never experienced, the first time I understood what harm reduction means is when I had the opportunity to travel to Seattle and see the Law Enforcement Assisted Diversion Program, or LEAD. Brendan, can you talk a little bit about that program and maybe lay out what it is, and then how harm reduction as a principle was infused within the sort of marrow of that program?
Absolutely. So law enforcement assisted diversion started in 2011. It started in Seattle. It's now been replicated across the country. We're in about 30 sites right now, from very large to very small, with about another 30 on their way. And what LEAD does is it gives an officer the opportunity at point of crime to, instead of making the arrest, divert the person away. So traditionally, cops have two choices. I make an arrest or I don't make an arrest. And when it comes to not making an arrest, it's sometimes a hard decision, because you're like, okay, I have accountability issues here, I have to hold somebody accountable for this, whereas now with LEAD, we give them a third option. That third option is diversion. So when we know somebody has a substance use disorder, has mental illness, is living in poverty, and those are the drivers of somebody committing that crime, mainly drug possession, but we've expanded in some places throughout the country. The officer has that chance to say, you know what, I'm going to choose not to arrest you as long as you'll meet with a case manager. And at that very point, once that person says yes, they call a case manager to the scene, do a warm handoff, the officer steps out of it, and it becomes a public health issue, not a criminal justice issue, which is where things like addiction and mental illness belong. There are certainly people that belong in jail and prison, but the folks that we're all dealing with, jail and prison is not going to help them out. So that case manager really starts to work with that individual to identify different things, different goals that might get that person to a place where they're going to be able to get into recovery, to stop using. One of the main things that we have is that abstinence is not a mandatory issue. Abstinence, in fact, with some people is not even talked about depending on where they are. So we don't require abstinence. We do use a completely harm reduction-based philosophy. So what that case manager does is they sit down in a very non-judgmental way. In the last panel, talking about trauma and talking about a lot of the things folks go through, we're all dealt a hand in life. And I'll speak for myself, if I was dealt a hand that had some different cards in it, I might have been myself on the other side of the law as opposed to being a cop. So the case manager really looks at things and says, what are some of the things you want to achieve? And we know that there's a couple big barriers. There's housing. Especially when somebody's using or somebody has a conviction, we have folks that automatically get excluded from housing. So they start talking to them about housing. They talk to them about employment. They talk to them about getting back together with their family and having some positive incomes, or relationships, and ultimately, they let that individual start identifying what it is that they need to become successful. And as they do that, they build trust. And when they build that trust, when that person's finally like, you know what, I've had enough, I'm ready to stop, guess who they go to? They go to their case manager and they say, I'm ready. What can we do? And the case manager does that. Our case managers are some phenomenal people. So, obviously I'm a retired cop. The cops do a great job, but our case managers, the way they engage with individuals in that non-judgmental way, and the way that they work with them on, let's face it, when you're sitting opposite somebody who is using heroin every day, most of us, our first instinct is to be like, you need to stop. And instead of that, they're like, okay, I'm going to work with this individual and not do what everybody else is kind of doing, saying this is what you have to do. And they come up with a plan for that person to get better and build that trust. And Seattle found that really the way that LEAD started in Seattle was actually not over the opiate crisis. It was about racial disparities and mass incarceration. The Seattle Police Department was getting sued by a whole bunch of advocacy groups over patterns and practices of enforcement specific to one specific area of the city. They had an extremely high rate of people of color getting arrested compared to what the population was. Lawsuits started, and they ultimately wound up around mediation tables, like many of us who have been sued before wind up around. One of the captains of the Seattle Police Department said, let's just, for sake of argument, say what we're doing is disparate. What exactly would you have us do? So this brave captain turned around and said that. And then the brave folks on the advocacy side, instead of being like, just stop arresting people, they looked and said, you know what, we really don't know what you should do. So they all sat down and said, we're going to come up with a plan. And those core components, had to do with that officer's discretion. It had to do with making sure it was a harm reduction focused model, because in Seattle and in Tacoma, they had started syringe exchange programs back in the AIDS epidemic. And they actually were able to really close the gap on folks that were being infected by sharing needles. So they knew that this could work. And ultimately, they came up with that plan to be able to give that officers those tools and really help change the mindset of not only the community, but of officers on how to deal with folks that have substance use disorders and mental illness.
Brendan, you were a police officer and then chief for 23 years, which means that you were a police officer, and I don't think chief yet, but at least a police officer during the war on drugs. What changed your mind? How did you evolve on this issue to the point that now you're talking about harm reduction and meeting people where they're at and using social workers out in the community? How did that happen in your mind?
Yeah, so I came on in 1994, and we were at the height of the war on drugs, which, by the way, we should never declare a war on our own people. Talk about a mistake, talk about things that we need to change. So, but I was part of that. When I came on, it was arrest, arrest, arrest. It was arrest a user, arrest a dealer who's actually only dealing because they have their own habit. It was arrest, and what we really were doing was the definition of insanity. So we were, in my mind, 99% of the cops, when they answer that question, when internal affairs, when they're doing the hiring process, says, why do you want to be a cop? We say, well, we want to help people. So I had this idea, as a lot of cops did, that when I was making that arrest, I was helping people. But yet I would see them out on the street corner an hour after I made the arrest having the same results. So that insanity, we do the same thing over and over again, and we expect different results. Well, one of the things that happens to cops, and it happened to me for a short period, thankfully it was short, is we lose empathy. We lose that ability. Kent was talking about humanizing people. We stop looking at people as human beings. I certainly stopped that. I was finally like, you know what, I'm fed up with dealing with everybody's problems. And thankfully, I moved into a position in our juvenile unit and started working with young kids who had just been through such unbelievable trauma in their lives. And it kind of finally clicked, like, okay, wait a second. If I had gone through this, if I didn't live in a household with both my grandmothers and my mother and two sisters who were constantly always on my case, God only knows what would have happened. So recognizing that, I got my empathy back, and I realized that we needed to do something different. And we started trying to work with our service providers, and although everybody at the table was like, yes, we can do something different, the police are still the ones that are out 24 hours a day, 365 days a year. So it came to be like, hey, at 10 o'clock tonight, we could really use some help. And folks were like, we're closed at 5. So when we sat down and talked about LEAD and we worked with our community, because by this point, there had been a large part of my career where it's safe to say that the citizens of Albany didn't exactly have a ton of respect or care for the police officers. And some could be said that that was opposite as well. As I started to work with my community, I realized that, I could say that we shouldn't have the war on drugs, but if I'm not doing something about it, I'm losing not only my legitimacy, I'm losing my entire police department's legitimacy. So it was a recognition that in community policing, we actually have to have the community at the table, and they have to be able to drive some of what we're doing. So when we got to that point where our community was like, hey, it's great you're saying all this stuff, but what are we going to do for real? LEAD, thankfully, we wound up going to a presentation, and I was like, you know what? This is exactly what to do. We can actually start from the very beginning of an officer's career recognizing that folks that have had trauma, folks that have addiction, folks that have mental illness, they need to be treated in a different way. We can get to the root cause of the problem and actually have a safer public, because arrest plus prosecution plus incarceration, that doesn't necessarily equal public safety. There are a whole lot of other pieces that come in, especially recognizing that change is going to take time.
Chris, you're on the ground here in Alabama. You are one of the largest treatment providers here in the state, and I know from speaking with you that one of the principal treatments that you offer is medication-assisted treatment. For those of us, I think, that do this work and travel around, we often hear the idea that you're replacing one drug for another. What do you say to those people, and how did you here in Alabama come to be such a proponent of medication-assisted treatment?
Thank you. Let me ask the people in the audience, how many of you treat people who have a mental illness? Raise your hand. How many of you encourage those people to stay on their medications? Raise your hand. Okay, if you raised your hand, I'm going to tell you why you need to support medication-assisted treatment. Because here's what happens with somebody with an opioid use disorder. Here's their brain, all right? They take heroin or other opiates.
Mic,
They have
you gotta use the mic.
Sorry, I'm a loud speaker, but I guess I'm not that loud. Here's your brain. As we're all sitting here right now, we have receptors and we have chemicals that go into those receptors. That's how we feel normal or pleasure, or at least not bad. That's our brain, all right? When you put heroin in there, your receptors get bigger to receive that heroin. So now you've got bigger receptors. At the same time, your body says, I don't need to produce the natural chemical, so your body stops producing the chemical to feed those receptors. So you got the big receptors that are hungry and you're not producing it. What happens? Your body says, feed me. And it does that by making you sick, really sick. Like you got the worst case of the flu, sick. And the only way you can change the way your brain is feeling is to put the chemical in. You have changed your brain. Now, what do we need to do to be able to help people who have this brain change, just like the people with mental illness? Take your medication. So medication, methadone and Suboxone, which is buprenorphine, fills those receptors so that people stop being sick. For somebody who has changed their brain, the drug is not dope. It is not getting them high. It is getting them to normal. So what you need to do when people who have changed their brain is you need to get them, just like your mental illness clients, to take their medication. When people who are have opioid use disorders try to stop themselves, the likelihood is that they're going to be successful is 10 to 15%. When you add medication, it increases to 40 to 50%. So if you will follow the science, you will have 4 times better results. If you continue to say, well, I don't like that because I don't like that they have to take a medication, it would be just like you saying to schizophrenics, you know, I don't like the fact that you have to take medicine. You just need to cure that brain disease with willpower in 12-step programs. Well, good luck with that. And so what I'm saying to you is that you have got to go back to your treatment people and tell them we're going to follow the science. Now, what does that mean? What that means in our case is that we provide the physician care and the medication at no cost, or $5. Why do we do that? Because we want people to take the medication. You know, if you have a program that says we provide medication, but poor people have to pay $100 or whatever, it ain't gonna work. You know it's not gonna work, so don't do that. So what I'm encouraging you to do is to you come to a conference because you want to learn something you didn't know, all right? And what I want to tell you is that the science tells you that people's brains need medication-assisted treatment, and your communities will be safer if you will follow the science.
Chris, I have a follow-up question. Who should be making decisions? So you mentioned 3 or 4 different types of medication-assisted treatment. In our room, we've got a range of criminal justice stakeholders, from judges to public defenders and prosecutors. Is there a medication you'd say everybody should be on Suboxone, or is it who should be making those types of decisions?
I'm going to tell you who should not be making the decision about what medicine. Anybody in the criminal justice system, all right? That is not your job. Do you sit on the bench and say, you've got schizophrenia, you've got bipolar disease? No. You say, go find an expert and do what the expert says. So don't try to tell somebody from the bench, judges. Don't try to tell somebody, court officers, because it's not your job to tell them. What you need to do is say, go to the professional, and the professional will tell me what level of care that you need. Now, one thing that's really important for you to understand, because, we talked about methadone. Methadone, you have to line up at the clinic every day to get it, okay? And so it's a real impact on the individual and on the community to have to do that. Suboxone treatment isn't like that. With Suboxone treatment, the doctor gives you a prescription, you fill it, and you go home and take it, okay? And it has a chemical within it that makes it unlikely to be able to shoot it and divert it, okay? So Suboxone treatment allows people to have a life. Methadone treatment means you got to line up in front of a dingy place, day in, day out, rain, sun, and it's a much more horrible experience for the individual to be on methadone than to be on Suboxone. So understand that it's not just the medicine that's different, but it's the delivery system that's different. And so what we've done in the past is we let people who had money and power got Suboxone, and people who were poor got put on methadone. All right? And what we're really proud to be able to say at Alethea House is we are not doing that. We are providing Suboxone treatment to poor people. We're not charging them a bunch of money. We're giving them the care that they need so that they can get the medicine that their brain needs. And I'm encouraging you to go back to your treatment communities and you sit them at the table and you say, are you providing medication-assisted treatment? And if they're not, help them make that happen. Because if not, they're not following the science, and they're going to end up in the criminal justice system because their brain needs these chemicals.
D.A. Clark, one of the things that's really interesting about your program, both of them, both HOPE and OR, but especially OR, is that it was in large part prosecutor-led. It was really your office who led the charge to get it created, and obviously working with Bronx Community Solutions and the Center for Court Innovation and the other players. I want to know, and maybe this is a question for everybody, but I want to start with you, DA Clark. How did you get all those players around the table? How did you convince them that this was the way to go, and how did you let them or get them to buy into your vision?
I guess just my experience in the criminal justice system as a whole prepared me for this, and maybe also the 16 years as a judge prepared me, and the last 3 being on the appellate court, where in order to make a decision you have to have a consensus of people. So I saw myself as a consensus builder, having had that experience on the bench and knowing what criminal justice was like, being an assistant DA for 13 years and then on the bench for 16, coming home, full circle back to the office. I knew that you had to have the community and the stakeholders involved in order to make this work. And the other thing is you could bring a whole lot of people together, but you don't necessarily get their buy-in. So it was a combination of bringing them together and really discussing what the problem was, what the impact it was having on all of us in our community and how we could make it better. So that's when I decided to bring a number of professionals from the criminal justice system, law enforcement, health systems. That was the police, the fire department, the courts, treatment providers, everybody together in the Bronx. And it was amazing how we all sat around and nobody knew what the other person was doing. Each one had an impact on the opioid crisis, were doing things on their own, but everybody was in their own silo and nobody really working together. And as we sat down and discussed the issues and found out what ability each agency had, then we figured out ways to partner with each other to get it done. So for example, in New York City, the fire department, the emergency service unit, the EMTs are part of the fire department now. So when they go out, they really see it firsthand. Even before somebody is arrested, the EMTs see somebody who's overdosed. They've saved hundreds of lives with naloxone and everything. But it's not necessarily reportable because of HIPAA and all kinds of things like that. But they felt like, okay, they found somebody, they saved them, the person has drugs, they got to turn it over to the police. But there was a treatment center right nearby. It's like, had I known you were there and you could have done something, maybe I didn't have to take them to the police because they have discretion. Take them to the treatment provider. Oh, I didn't know you were providing this service, and so on and so on. So once everybody saw that and saw that we could really help people, because like you said, you got into this profession to help people, this was a way for us to really help those substance users and really try to make a difference in the community. And that's how I got the buy-in, because everybody saw how they were interconnected and we could make it work.
Brendan, the lead model also really depends upon partnerships, and in particular the partnership between the DA and the police. Can you talk a little bit about how, particularly when you're expanding lead models in different jurisdictions, how do you get those two and other criminal justice players on the table?
So yeah, I mean, we consider lead not owned by one entity. We consider lead a collaborative, and that all of the partners at the table all own good and bad. So when great things happen, we all celebrate it. When bad things happen, which thankfully there's not a lot of bad things, but when something bad happens, we all work on figuring out how to address that and not point fingers at each other. Something that truthfully can be done a lot, because normally we all work in silos and we all say, okay, this is my program. No, that's your program. But what LEAD does is, because of that philosophy of having it be a collaborative, it gets the partners around the table and it gets everybody to agree to things. So I've signed probably 1,000 MOUs in my career, Memorandum of Understanding. LEAD was really the only one I felt like actually meant something, because it actually got folks to say, this is what I'm going to dedicate, this is going to be our philosophy, and we're going to agree that we all own this and we're all going to work together to get it done. I'm not going to tell you that across the country, all law enforcement, whether it be police or district attorney, are like, hey, this is great, let's go ahead and do it. In fact, I get a lot of pushback. There's a lot of folks that are like, you're telling me we're not going to arrest somebody? And it's like, yeah, we're not going to arrest somebody. What good is that arrest doing? So it takes a lot sometimes to get over that. It also takes a lot, like between police and DA, sometimes to be like, well, we need to hold a hammer over their head. So similar to the whole, this is carrot, carrot. It's like, we don't have a hammer. The only thing we're requiring somebody to do is do a quick assessment. So when we talk about that and we say that charge is going to go away, sometimes The law enforcement piece, the criminal justice piece, isn't necessarily going to go with that. And it's really taking things to a point where, we can talk about all the studies, all the research. When we start talking about individual stories, when we start talking about like, hey, who do your officers deal with every day? And it's like, oh, this one guy has been arrested 50 times, but we need to handcuff him. He needs to be arrested. And it's like, well, you just told me he's been arrested 50 times. What's changed? Has anything changed in the community or with him? And it's like, well, no. It's like, okay, well then what's the issue? We can try something different and get better results, and we have proof of that.
Chris, I skipped over this before, and then my wheels were turning as I was sitting here. You said you offer Suboxone for free or for $5. Who is paying for that?
One of the things that everybody should know is that the federal government has recently passed the CURES, C-U-R-E-S, the CURES funding, going to every state. So every state now has some additional resources to be able to provide this treatment. And so you need to be with your legislators. Look, we all know that state money is tight, but this is federal money that somebody's going to decide in your state how this is going to be spent in the next 90 to 180 days. So if you believe that you want the best care for the people that you serve, I promise you what you need to do when you get back is say, who is my state agency that handles our money, and how can I get an appointment with that person so I can ask them and the other people in my state, how are we spending our CURES funds? And, I've been around 40 years, and there's about 3 or 4 times that there's been big expansions of federal money, and we are now living in that opportunity. So don't let it go, because here's what happens. Once they decide where that money's going to go, you're never going to see it again. So if you want medication-assisted treatment, including medication that's affordable to the individuals that you serve, I encourage you, go back to your state agency that handles substance use treatment funding and ask them, what are you doing with the CURES funding? And if you don't like their answer, you need to go advocate, including with your legislatures, to say, no. In our community, we're going to follow the science, and therefore we want to be able to make sure that our opioid-addicted individuals have access to care.
And I will say, for those of you who are not in the funding innovation panel yesterday, the Department of Justice, Bureau of Justice Assistance, yesterday afternoon released about $140 million in opioid funding. Yes, we can, and hopefully a lot of the jurisdictions in this room will be applying for and will indeed receive it. There's 6 categories of funding. It's a real range of opportunities and options for the jurisdictions here. I will encourage you I forget what time we end today, but whatever the minute after that is, to go look up the solicitation and start your applications. They're due at the end of the month. They're due on May 30th. So get your grant writers on it. D.A. Clark, you have a different funding story. I'm going to be a little cheeky and ask, how is OR funded?
Well, there was no funding. Everybody used the resources that we had and just made it work. So the courts, has a budget. They have to handle dockets. So we have, the ability to see those who are accused because that's their job. My office, I have an Alternatives to Incarceration Bureau who handles that. So Aisha Green, who is the chief, she sits there in court as Bronx Community Solutions assesses the people, and they have funding also through CCI and other things. And we just make it work with what we have. And the savings are tremendous because, like I said, we're saving lives. Now, we just started in December of 2017 until the present. So I think that we've had like 700 people screened, 450 people who were eligible, and I had the numbers here. 65 people who actually went into the treatment, and 15 people who have now completed it. So just from December until now, we saved 80 lives because these were the people that were at the highest risk of overdose. And I forgot to mention, the reason why they're even at a higher risk is the entrance of fentanyl into the drugs now. So these high-frequent users who, they're used to getting high, they know what thing, they're getting, they get it from their daily dealer or whatever. basically it's the same thing over and over. But with the fentanyl now, people are dropping dead immediately. And that's something new that they're not used to. So those same users that go to their same place to do it or whatever else, they do it that one time and they're gone. So this is why this is so important to do this, because the key is to saving lives. And so far, so good. We'll get the quarterly numbers of overdoses in the county in the next couple of weeks, and then we'll really be able to see how we're doing. But we had 376 people die of overdoses in the Bronx. And if we were a state, we'd be like 15th in the nation of drug overdoses. So that's why I knew I had to do something.
Brennan and Chris, I'd love to hear each of you also talk about some of the results from your programs.
So, we are now in large and small. So I'll just talk about Albany a little bit. So Albany's had 130 diversions. So Albany started doing diversions April 1st of 2016. Like everywhere, it takes some time to build, but ultimately they've got 130 diversions. I'll tell two quick tales. So the first is the first participant. So officers go to a large shopping center, to a Walmart. They go there for a shoplifter. Albany, we expanded some of our criteria. We wanted to capture some of those crimes that were committed due to addiction. So the officers get there, they had done outreach. Walmart Loss Prevention comes out and says, hey, I've been talking to this guy. You guys came to talk to me about that LEAD program. I think this would be a good candidate. So they sit down, they talk to the guy. The guy had been arrested 44 times. 40 for petty larcenies, which in New York is a misdemeanor, 4 for burglaries, which is a felony. He'd been convicted 22 times. 20 larcenies, 2 burglaries. They start talking to the gentleman. He is using $300 to $400 worth of heroin a day. And he's not doing that to get high anymore. He's doing that to maintain a level so he doesn't get sick. Gentleman isn't employed, not stable housing, says, hey, I've been in a program before. I do use methadone before. I did well. Granted, I'm not doing well now, but I'd like to get back involved in a program. So they make a diversion that day. There's all kinds of hoops and hurdles I could talk about that everyone had to go through to get this guy into one of our 2 clinics. Thankfully, he got in, but that was April 3rd of 2016. He has not committed a crime since. So that in and of itself tells you the power of what happens when a case manager intervenes and gets all of those things that somebody needs to get to become stable enough to get the treatment they need. The other one I'll just talk about is we're also looking at the healthcare side. So we're actually using Medicaid funding in New York to pay for case managers. Our county just did a kind of quick view of 4 participants and figured that those 4 participants, we were saving over $100,000 since they have been involved in LEAD. One of those gentlemen was $75,000 himself, based on the number of times he was going to the hospital. So Seattle has 4 outcome evaluations that are on the site, leadbureau.org. We know a 58% reduction in recidivism. We know the costs have gone down, and we also know that participants are more engaged and actually in a better place in their lives.
And I guess one of the things that we're most proud of is the work that we do with pregnant women with opioid use disorders. If you go to any hospital and you go to the neonatal intensive care unit, what you're going to see is a whole lot of babies who are in withdrawal. And we have got to be able to understand that when women are addicted to opioids, they're not usually real concerned about consistently using contraception or taking birth control pills. And so the likelihood that a woman who, and oftentimes you get women who are trading sex for drugs. And so, pregnancy is not an uncommon situation with women with opioid use disorders. And so we provide gender-responsive treatment to women who are pregnant so that they can come into treatment, be placed on medication. And then, that baby is going to be born addicted. That even when they're on medication, that baby is going to have a period. But since we can work closely with our doctors, we can make sure that that happens in the best situation. The other thing is that most pregnant women who are using drugs are not in prenatal care. So being able to help them get into medication-assisted treatment for their addiction also increases the likelihood that we're going to get them into appropriate prenatal care and that they're going to be able to have a healthy delivery.
We've got a little bit over 10 minutes left. I want to see if there are any questions from the audience, and there are, so good thing I paused. And somebody will be around with a microphone.
Good morning. My name's Dexter Cunningham, and I'm a sergeant here in Birmingham with the police department. My question is posed, I guess, to half and half on the panel. Chris, you made mention that from a substance abuse point of view, the poor get methadone, the rich gets the other product.
Yep.
And so for the DA, ultimately, this opioid crisis rests at the seat of Big Pharma. Big Pharma has used misguided marketing and basically have gotten some doctors to go ahead and lie and say that these opioids are good for long-term pain management and they're not addictive, and that was a lie. If you would look at some of the statistics for the companies that basically have become multi-billionaires 7 times over for being rich on the backs of these poor people who had an accident and they've gotten addicted. What do you see, what needs to be done, and where is the lead on holding them accountable? Because for them to pay a $50 million fine means nothing when I've generated $3 billion in profits. And it's done off of misguided marketing and actually just downright lying. And I've been in law enforcement 30 years, and it makes my hair stand on edge to see this go on, and literally makes me sick to my stomach that those who have gotten rich off of other people's addiction and actually created addiction. So my question is, how do we hold them accountable when there are vestiges in our DEA that are actually scared to go after them because they have the lobbyists and the money? And for me, I'm just kind of fed up with that, and there has to be something that needs to be done.
Well, I know that DAs and more importantly, attorney generals across the United States are looking into this, and I know that the Attorney General in New York State, well, there's things going on there, but he was one of the people at the forefront of that, at least, who has, they've filed lawsuits against Big Pharma. So I think there's at least 19 AGs across the nation that are suing Big Pharma right now for the very reasons that you talked about, because they have created this problem. Another thing, different states, and I know New York State has done it as well, is that they started, they put regulations in place so that doctors can't write those prescriptions for any amount. It's like in New York, it's like you only get 7 days worth now. And there's also a requirement now that even when you're in the hospital or they're prescribing it, there's different warnings that they now have to give you, which wasn't happening before. You know, you have like a hangnail, they give you, you know, whatever opioid, and they don't tell you anything, and they don't tell you that you could get addicted, you know, to it as fast as a week or the 30 days that you're on it. So we have those regulations as well. So they've done things to cut back on the way pharma has been able to, you know, continue the wrongs that they've created in this area.
Other questions? I know,
So at one point I understood that doctors were restricted in the number of Suboxone prescriptions they could write. Has that been lifted?
It's been modified. So what happens is a doctor, the first year that they prescribe, they can prescribe to 30 patients. The second year they can prescribe to 100 patients. In the third year they can prescribe to 275 patients. And recently it's been added that nurse practitioners and I believe physician assistants can also become eligible to be able to prescribe. But that is a problem because most of the prescribers are serving people with money. You know, we tried to open up in Huntsville, and we wrote a letter to every single provider, you know, offering to pay them, and they all said our panel's full with people who will pay us a lot of money, and so that is a challenge. But hopefully you know, some of the other things. But let me just tell you what happened. We went to the hospital, and they're interested in having all their residents trained to be able to be Suboxone prescribers. So one of the things that we can do is to go to the younger doctors and nurse practitioners and train them so that they can then be prescribers for the rest of the, you know, for as long as we need them.
Is Vivitrol effective in addressing some of these problems? Vivitrol.
The science on Vivitrol is less, clear than the marketing of Vivitrol. Because here's what's happened. Because we know, y'all say, I don't want to get them on Suboxone, and then the people on Vivitrol will say, well, good, we'll make them do Vivitrol, even if that's not what they need. And so what's happened is the criminal justice system has been used by big pharma Vivitrol to force people onto Vivitrol when that's not the right medication. Vivitrol, by the way, costs $1,300 per injection. So in answer to your question, some people do well on Vivitrol. The science on Vivitrol is not well developed, and big pharma is going to try to come. You know, they came to our Department of Corrections and said, we'll give a free shot to everybody leaving leaving prison if you'll make sure that they'll get on it when they leave the community. Well, wasn't that a real generous thing for them to do? You know, so don't fall into this big pharma Vivitrol. Vivitrol is appropriate for some people, but they're going to try to get you to force people on Vivitrol instead of on Suboxone because they make more money. And by the way, there's articles about them doing this in states where they went to the legislators and got them to put it into legislation, because they wanted to be able to lobby to be able to get people to be forced to use the medication.
Other questions? We have one here.
Hello. My name is Greg Gill. I'm from the Eugene Municipal Court. Mine is a two-part question. The first part is for DA Clark. You mentioned that you have what we call a pre-plea diversion program, where the person comes in and engages in treatment and then will receive that treatment. The case can be dismissed without the person having to actually enter a plea. Is that correct?
Yes, that's correct.
And so it's hard to reconcile demanding pure abstinence from substance during a treatment program. So my question is, how long do you keep a case open before someone's put back into that traditional system? And then the second question is for Mr. Cox, and it also has to do with diversions. And you've given your officers this third option, the discretion to offer a diversion. Was that something that the officers took hold of, or did it take a while to convince them that this is something they ought to offer? Thank you.
All right, so as far as the OR program, because we have two programs, I didn't talk about the other one, HOPE, which is heroin overdose prevention and education. Those are for people that are newly coming into the system, low-level crimes where the police, they take them to the precinct and they're met at the precinct by those peer counselors. The last panel talked about those peer counselors, and they take them straight to treatment. What we do is hold the charges in abeyance. But with that one, there's a certain amount of time that they have to engage before those charges may be written up. With the OR program, they come in, and because it's pre-plea, and everybody's a different individual, we take it as long as they want to be engaged. So we have a judge who's very familiar with this. He's very in tune with it, and they want to make it work. So they give them the chances, and you know what? They're not always going to be successful, and those of you in this room know that that's what happens. It takes some time. They're not going to be successful on the first try. So we give them, several tries in order to do it, and so there's no real number. We do it, it's based on the individual. We see how they're doing, whether or not they're, progressing in any way, and if it should come to whatever time frame it is that they need to go back to the regular track, then we do that. The thing is that the defense bar is on board with this, so they waive any speedy trial problems, any of those issues, the criminal justice issues that go with the case are told or on hold until that person, if they go back into the system, then they're put back in the same place they were from the beginning.
So, officer buy-in is the key component of making lead work. And I'm certainly not going to tell you that every cop is like, woo, we're going to divert people, we're not going to arrest them. So there's work that has to be put in. The first piece of work has to be that officers get trained, and not just in how to do a diversion, but why we're doing diversion, what the philosophy is, why we're going to harm reduction, what they might see in the end, and how this will ultimately improve their job. So we see a lot of cops that are like, yes, right from day one they're on board, and other cops are like, I'm not doing that. And what we do is we try to maintain the fact that, well, this is your discretion. So if you decide not to do it, we're not forcing you to do it. But what we've seen across the country is officers that have said, I'm never diverting somebody, that based on an individual circumstance, they were like, okay, I'm going to divert this person because I don't want to fight with them in the middle of Dunkin' Donuts. So I'm going to figure out a different way to do things. And when they see that success, they actually do more. Just to add on the success thing, so success is defined differently for each participant. We have to look at people as individuals. So for success for one person might be that they got into treatment, they're in recovery, and they're great. Success for another person might be we got them from stopping to drink on the street corner to drinking in their apartment.
Maybe one or two more questions, depending on length. None. Okay, then I'm going to ask Brendan one more question. So you work for the LEAD National Support Bureau. We've mostly been talking about LEAD as a program. What is the LEAD National Support Bureau, and if folks are interested, what's the mechanism for that?
Absolutely. So the LEAD National Support Bureau grew out of the fact that Seattle was getting just inundated with requests for help. So recognizing that there was a need for technical assistance across the country for folks looking to do LEAD, the Bureau was started. It's got a number of, there's not a ton of us, but it's got a number of us that come from different professions that ultimately help out folks when it comes to exploring what LEAD is, learning about it, and then all the way to implementation and operational of the program. If you go to leadbureau.org, there's a whole bunch of information, including all of our contact information. And what we'll do is we'll help provide that technical assistance. There's a number of different funding pools, including from BJA. So BJA, National Network for Technical Assistance, I think is the name of it. If you go onto BJA's site, you can apply to get technical service from the Bureau to help bring LEAD to you. But I know money's tight for everybody, so what I would say is that reach out to myself. I'll certainly stick around and give you my card, or go online and see our contact information and get in touch with you, and we will walk you through A to Z.
And DA Clark, I know your program does not have a National Support Bureau, and you have also been inundated with requests for visits and more information. Is there anything you'd like to say to jurisdictions here, many of whom are from courts, who might be looking at starting an opioid docket or an opioid court or an overdose prevention program like yours?
I just say that you have to keep an open mind and do it. I started out as a prosecutor 32 years ago, back when we had the war on crime. And when you're in the middle of it, you don't realize the damage that we were doing at that time, filling up the jails with people who were drug addicted or selling drugs. And now you see what's going on. It's a different world. So to be a prosecutor in the 21st century means something that was way different in 1986 when I started the nail and jail. That was the approach. We thought we were doing the right thing. But now you got to keep an open mind, think outside the box, and just really work on building the trust of the community, because they need it. Even if they don't see it, it's up to you to convince them that it's something that's needed, because sending, substance abusers to jail is just not working. So we need to save lives. This opioid epidemic is real. So by all means, come to the Bronx Seat. We just started it, and it seems to be working. And, you just got to tweak it if it's not working, and go to conferences like these to get more ideas. So it's the way to go.
Well, thank you all. Please join me in thanking our three excellent panelists. There's obviously much more to discuss, but unfortunately, that's all the time we have for this subject.